And my thanks to the organizers of the KRA conference for inviting me to be with you today. So if I could share my presentation, requirements for implementing a deceased donor transplant program and embarked on living donor transplants and the medical resources. The legal framework that needs to be in place is the Tissue or Anatomy Act, brain absent motor responses, and the patient presents with loss of consciousness. Paramount in transplantation is education. Importantly, education of medical personnel as well as the public and communities need to be educated as to the importance and value of organ donation and organ transplantation. In South Africa, we have a further situation where a ministerial advisory committee is in place.
We're having some bit of technical challenges with the sound, but
living donor transplants and transplants.
Okay, go back. Okay, let's start.
Jambo, greetings, friends and colleagues. It's a great pleasure to be with you today, and my thanks to the organizers of the KRA conference for inviting me to be with you today. So if I could share my presentation. It wants to speak on the requirements for implementing this donor transplant program in Africa. We are well aware of the options for chronic kidney failure, various forms of dialysis modalities, and kidney transplantation. Many of us have embarked on living donor transplants, and it is now opportune for us to look at setting up deceased donor programs. So what are the resource requirements? This slide summarizes what needs to be in place before one can embark on this program. Firstly, the legal framework and the medical resources, laboratory facilities, and funding all go hand in hand to determine the success of such a program. And subsequently, one needs to register donors and recipients in each transplant unit, as well as report outcomes to a registry, which could be national or regional, such as the AFRAN Renal Registry. The legal framework that needs to be in place is the Tissue or Anatomy Act, brain death law, and a law that regulates organ and tissue transplantation and also includes issues of consent and commercialism. Now, looking at the clinical criteria for brain death, one needs to generally have an obvious cause for brain death in the absence of drug intoxication or poisoning, absence of electrolyte or acid-base imbalance, and usually there's an acute neurological catastrophe that has resulted in apnea, absent brainstem reflexes, absent motor responses, and the patient presents with loss of consciousness. As far as consent goes, consent could be given by the individual themselves who have signed up as organ donors in various forms, or by their next of kin, or in some instances, in some countries, presumed consent is present, where it is assumed or presumed that an individual is an organ donor unless they have recorded otherwise. Where there is no next of kin available, legal consent may be given for transplantation. Paramount in transplantation is education. Importantly, education of medical personnel as well as the public and communities need to be educated as to the importance and value of organ donation and organ transplantation. In South Africa, we have a further situation where a ministerial advisory committee is in place, and they advise on all unrelated living donor transplants and transplants from foreign nationals that may happen in South Africa. And these can only take place if the National Minister of Health has signed consent to these transplants occurring. These are part of the procedures to prevent commercialism and organ trafficking. We are well aware of the Istanbul Declaration, which has been promulgated and endorsed by the Transplantation Society, the ISN, WHO, and has been endorsed by many of our national societies. Commercialism is illegal in most countries. Looking at further resource requirements, one needs well-trained medical professionals. Firstly, a surgeon who has excellent general surgical skills and specific skills in vascular and neurological surgery. A transplant physician who is skilled in nephrology and transplant medicine, including immunosuppression. All personnel and facilities need to be available around the clock to ensure success of a deceased donor program. And the donor will need to be maintained in a high care or intensive care setting until the organs are retrieved in an optimal condition. There are critical issues for sustainability, such as an adequate donor pool, large numbers of recipients to be available to match specific donors, availability of a range of immunosuppressive agents and other medications, and then it's ethically feasible and required that if graft fails, one needs to have options to sustain life with various forms of dialytic therapy, and of course, sustained funding to ensure the smooth running of such a program. One needs skilled laboratory services to sustain and support a transplant program. Radiology, of course, immunology, we'll discuss some of these further, clinical chemistry, microbiology, facility to do drug levels, and of course, histopathology with the services of a skilled nephropathologist. Looking at immunology, the basic requirements for a deceased donor transplant is to be able to have ABO blood groups and a lymphocyte cross-match available. HLA typing is advisable, as well as recipients having to be surveyed for preformed antibody levels. Looking at HLA typing, one does both class 1 and class 2. HLA antigens are found on chromosome 6, and currently one does DR, DQ, and DP matching on class 2. And what is the value of HLA compatibility? With identical twins, obviously these twins are identical as far as HLA goes. And occasionally, in about 25% of cases, there's a possibility of siblings being identical. The more common situation is that in 50%, there will be a haploidentical. And graft survival is best in the long term with 6 antigen match or haploidentical matches, or if there's DR followed by B matching. So how does one select a donor? There should be absence of kidney disease, absence of active infection and transmissible agents, and absence of malignancy. deceased donor needs to have brain death declared, and brain death needs to be declared by a healthcare professional who has graduated for more than 5 years, who is not a member of the transplant team. The donor ideally should be aged between 2 and 60 years. And in the optimal situation, hypertension, diabetes, malignancy, except for malignancy localized within the brain, infection and renal dysfunction are exclusion factors. When one is resuscitating the donor, one needs to ensure that the systolic blood pressure is more than 90 millimeters mercury. The urine output exceeds 0.5 milliliters per kilogram per hour. And the donor could be allocated according to various point systems, which could be locally, nationally, or regionally in place, depending on the number of programs and the number of recipients and donors available. Looking at expanded criteria donor, generally one might exclude donors who are hypertensive, died of a stroke, got renal dysfunction, and one in an area or instance where there's a great shortage of organ donors, one might consider using these so-called expanded criteria donors in individuals who are older than 60 or 65 years of age. And it's important to look at graft outcomes in such donors. Expanded criteria donors have a reasonable graft survival of 82% in 1 year, which declines to 68% at 3 years and 53% at 5 years, compared to 70% in deceased donors at 5 years. Looking at other developments that ensure successful transplant outcomes, surgical techniques are constantly improving. The graft itself is stored in preservation fluids, and there's various research looking at optimal fluids. New immunosuppressants are being developed, and these have made a great difference in long-term graft outcomes. And of course, various antibiotics, antifungals, and antivirals are important in maintaining the recipients infection-free. When a potential donor is available and brain death has been declared, the important preoperative initial tests are those of kidney function, to exclude diabetes, to check the blood group, and to do a lymphocyte cross-match with the available recipient pool, and also to exclude various transmissible agents such as HIV, hepatitis B and C, cytomegalovirus, and syphilis. Whereas CMV per se is not an exclusion, but one might want to give antivirals to the recipient who could be CMV negative in the presence of a donor who's CMV positive. As far as recipients selection in a deceased donor program, one needs to know what the primary cause of kidney disease is to determine if there's a high risk of recurrence or not. And it's important at the outset, before recipients are listed for transplantation, that unsuitable candidates have been ruled out. These are individuals who may have significant other organ dysfunction, significant vascular disease, or a recent malignancy, though the criteria for these are changing with new knowledge and research. And it's important to know the level of preformed antibodies that recipients have, and a level of less than 30% does not impact on graft survival. Diseases with a high risk of recurrence after transplantation are FSGS and hemolytic uremic syndrome, and the conditions listed below have a low risk of recurrence. Intermediate are other conditions such as IgA, nephritis, etc. Requirements post-transplantation is expert monitoring, where graft function is monitored on a regular basis, and the clinician monitors for infection, malignancy, and any adverse drug reactions or drug effects, manages any hypertension, diabetes, hyperlipidemia, and other conditions that may be present. And at all consultations, the clinician needs to ensure that the transplant recipient understands the need for adherence to the drug regime. Drug levels of immunosuppressants may require monitoring, and it's optimal to do so as a therapeutic window for the calcineurin inhibitors is very low, and chronic toxicity could be present even at recommended doses. And one needs to be aware of potential drug interactions when patients are on therapy with calcineurin inhibitors and also on antiretroviral therapy and antituberculous treatment. And they need to be very carefully monitored in these instances. Factors that determine transplant outcomes. I'll show you some data looking at deceased versus living donor transplants. The level of sensitization matching is also important. As I mentioned, a 6-antigen mismatch does worse than a 0-antigen mismatch. Racial differences can impact. One sees that long-term outcomes are much higher in the European situation compared to the US situation, where there's a great diversity in Black populations versus European populations. Recipient age may be important in that children and adolescents have a much brisker immune response. Looking at the center effect, outcomes are dependent on critical mass, and therefore it's important that transplantation occurs in the center where there's a substantial number of transplants done. And it's important when embarking on these that in the first instance, one centralizes transplantation in a country and thereafter sets up satellite or further units as the numbers increase. And of course, the choice of immunosuppression has made a big difference on graft outcomes. In certain instances, one might need to use cyclosporin or calcineurin inhibitors with mTOR inhibitors, and also one might to use initial therapy with ATG or other such agents in high-risk patients. Looking at costs of transplantation, the USRDS has reported high costs of immunosuppressants and agents against cytomegalovirus, both just over $6,500 in the first year, with other agents like for hepatitis C and other medications taking a smaller part of the budget. Interesting when one sees the cost of antihypertensives is quite low. If one wants a successful transplant program, this should be sustainable, as any chronic program should be. Programs should be affordable with long-term funding assured, and one needs to ensure that expertise and infrastructure is available together with constant availability of all required medications. Looking at the number of transplants in the USRDS, one could see that living donor transplants are about 25% of the total transplants performed in the US, both in numbers and in their rate. And looking at graft survival, while the graft survival of deceased donors is slightly lower at 1 year and 5 years, one can see that the curve converges after this, and there's almost a 15% difference in graft survival at 10 years. Unlike the data in the EDTA ERA registry at 10 years, while living related kidneys do better. Deceased donor transplants aren't too much inferior compared to the US. Looking at costs of transplantation, this depends on the various agents used, but in general, it's thought that kidney transplantation in the first year is much lower compared to hemodialysis and peritoneal dialysis. This slide shows you the detailed criteria for determination of brain depth, and there are various texts that are available in the literature. And I will leave this for you to peruse, and we'll be happy to entertain questions. Thank you very much